go, go, go. That's the birthday. That's the birthday. Yo, Z-Pack! This episode is made possible by the generous sponsorship of Athena Health. Athena Health partners with hospital and ambulatory clients to drive results. They offer network-enabled medical record, revenue cycle management, patient engagement, care coordination, and population health services to build Health 3.0. Yo, get back to the work you love doing. Athena Health. Free up. What up, Z-Pack? It's your boy Z-Dog MD and your crew, Tom Heineber and Logan Stewart on the board.
Hey, girl.
Yo, we're going to cut to the chase because today there was an economist who accused doctors of being Scrooge McDocs.
Oh,
yep.
Snap.
Of jumping into a pool full of gold doubloons and bankrupting America. Why?
Why? Because they're evil.
Life is like a hurricane here in Duckburg.
Raised cars, lasers, airplanes.
It's a Doc blur.
Anyway.
You might solve a mystery or bankrupt America. Doctors, oh. So this is the thing. It's an article in Politico. We've linked to it here. Tom will pin it in the thing, maybe, or he won't. And I want to go through this. I'm going to give you a real doctor reads an article about how rich doctors are and they need to be stopped. And you will probably already start to guess where I fall out on this. And this affects everyone in healthcare, not just doctors, because they are talking about, are we the reason why healthcare is so expensive? Ha ha! Punchline? Someone's going to get punched. Check it. The Problem of Doctors' Salaries by Dean Baker, who is now persona non grata in this studio. Okay, Dean, you try to come here, I will cut you. The United States pays more than twice as much per person for healthcare as other wealthy countries. We tend to blame high prices on things like drugs and medical equipment, in part because the price tag for many life-saving drugs is less than half the US price in Canada and Europe. Well, this is interesting because didn't he just say we pay more than twice per person? He basically said the same thing 2 sentences in a row.
You're a shitty writer, Dean!
You know what? Talk about waste. You want to talk about waste? Those are wasted words. Let's keep going. But an unavoidable part of the high cost of U.S. healthcare is how much we pay doctors. Twice as much on average as physicians in other wealthy countries. Because our doctors are paid on average more than $250K a year. I don't know what doctors these are, Tom Heineber, but it took me a long time to ever get paid that much. Even after malpractice insurance and other expenses, more than 900,000 doctors, that seems a little high, that are actually practicing. That means we pay an extra $100 billion a year in doctors' salaries. Extra, relative to the rest of the civilized, developed world, he's saying. That works out to more than $700 per U.S. household per year. We can think of this as a kind of doctor's tax. All right, for a second now, let's just sit off. Okay, I'm gonna do a little math. $3 trillion. In healthcare spending a year.
Right.
100 billion is the extra that we pay doctors relative to the rest of the world. That doesn't seem like the primary cause of disastrously high healthcare costs, does it? Maybe I'm doing math wrong?
You know, they probably like to work small to big, Z. Start off with the
little things?
The little things.
Little things.
Paying the people that are doing all the work.
Yeah.
And then moving on to other stuff like the insurance companies raping everyone.
Yeah, maybe just like destroy the morale of the people who are actually delivering the care, who sacrifice their 20s, rack up $200,000 to $300,000 in medical debt, and the opportunity cost of not working in their 20s and studying, and screw them so that big pharma, big insurance, medical devices, hospitals, and administrators, because administrative costs in the U.S. are higher than anywhere else per unit in the world, in the developed world. Screw all that stuff. Let's talk about doctors. You see where my bias is here, but let's continue down this because we do want to rationally kind of look at this and see, could there be a reason that doctors are Scrooge McDocking the entire economy? All right, so doctors and other highly paid professionals stand out in this respect. Our auto workers and retail clerks do not in general earn more than their counterparts in other wealthy countries. Well, auto workers and retail workers don't work in a convoluted, messed up healthcare system where they have to go $250,000 in debt to become an auto worker or a retail worker. That's one of the obvious differences already. Most Americans are likely to be sympathetic to the ideas that doctors should be paid, well paid. After all, it takes years of education, long hours, blah, blah, blah. People generally respect and trust their doctors, but they likely don't realize how out of line our doctors' pay is with other doctors in wealthy countries. You know what else they don't realize? That There are fewer doctors per capita in the US, which means we work harder and have higher volumes. We have less work-life balance than other countries, and our tuition isn't subsidized like it is in most other developed countries. So it is a very different milieu, and again, we're talking about total physician fees in the country, 10% of total medical spending, and they're saying half of that is overspent relative to other countries. That is a relative drop in the bucket compared to what's going on. But cutting doctors' salaries in half, if you just did that overnight, you would find a mass exodus because people would be like, well, fuck it, if I'm gonna get paid what I'm getting paid in Europe, then I'm gonna go work and have a better lifestyle and have social network and support that I have in Scandinavia. Why the hell should I work here where I'm busting my ass? So, and I'm gonna abandon my debt and I'm just going to default on it.
It's kind of like how the Russians subsidize their Olympians, but we kick their ass anyway because America. You know
That's
what I'm saying?
right. Mm-hmm. You can inject, you can inject tons of steroid in Victor, but we're still going to beat his ass. You know why? Because, like you said, corn-fed.
Hell yeah.
Yeah, subsidized corn-fed. Anyways, so as an economist, he says, I look for structural explanations for pay disparities and the like. When an economist like me looks at medicine in America, I don't know what the fuck I'm talking about because I'm an economist, not a medical person. Sorry, I mean, whether we lean left or right politically, we see something that looks awful lot like a cartel. Oh snap, he just called us a cartel, the doctors. Let's see what he means by that. The word cartel has some bad connotations, you think? People think about OPEC. People think it means that what it really means is that it's not entirely negative. It means that suppliers of a good or service have control over the supply. So this control can be used to ensure quality, as is the case of many agricultural cartels around the world. However, controlling supply also lets the cartel exert some control over prices. So how does that relate to doctors? In the US, the supply of doctors is tightly controlled by the number of medical school slots. This is absolutely true. And more importantly, the number of medical residencies. So it doesn't matter if you go to med school, it doesn't mean shit. You are a doctor in name only, as much as you're a doctor if you go through naturopathic school. You're not a real doctor, right? You have to do a residency to actually be able to properly practice as a physician in the United States. So those numbers of slots are set by the American Council of Graduate Medical Education, or ACGME. A body dominated by physicians organizations. So in the United States, unlike other countries, we require our docs to complete a US residency program to practice. I actually didn't realize this. I thought this was true everywhere, but it's not. You have to complete a US residency program to practice here, but you can take your US training and practice elsewhere through jumping through some hoops, but not having to repeat residency. When my parents did a residency in India, they came here to Overlook in New Jersey, in Summit, New Jersey, and repeated their residencies because they couldn't practice here without a second residency, and that sucked really bad. So for them, because they were pretty well trained. So this means that the US doctors get to legally limit their competition. As a result, US doctors receive higher pay, and like anyone in a position to exploit a cartel, they also get patients to buy services, i.e. from specialists that they don't really need. All right, let's unpack this all for a second. So Tom, what they're saying is,
oh, I know what they're saying. They're saying that you motherfuckers have a monopoly on working your asses off, not seeing your family, getting chronically underpaid, delaying gratification until you don't even have a life anymore, and dying early from all the stress.
That's right.
You have a monopoly on that. And you're evil. You should be stopped.
You know what? I don't want young people to have the same wonderful life that I have of suffering. If anything, we're trying to keep that away. But it is true. The effect has been less doctors per capita than elsewhere in the developed world, which means payment per doctor is higher. Volume per doctor is higher by definition. Yet, we have the worst outcomes in the developed world. Apart from research and cancer treatment and things like that where it's pretty decent, the rest of our outcomes are abysmal compared to the developed world. So what are we getting with fewer doctors who get paid more? Well, not necessarily the best outcomes. But the thing is, why would they limit these slots? Well, again, reducing competition. That is a cartel-like behavior. But now things are starting to shift because we're realizing, hey, baby boomers are retiring, shit's getting real. The doctors in practice are like, this is too much. Well, you have a couple options, right? You can loosen up restrictions on nurse practitioners and PAs and allow them to practice higher and higher up to their licenses or independently, which has generated a shitstorm among physicians. You think they get competitive with their own, and keeping out resident slots, they will go ape shit.
And why do they keep out resident slots?
They're keeping out resident slots because, again, if there are too many doctors, the overall pressure on volume and pay goes down.
Right.
And this has historically been the case.
And doesn't Medicare provide the support for residency slots?
So here's, and let's go down this because we get to that exactly. So there are two parts to the high pay received by our doctors relative to doctors elsewhere, according to this economist, Dean. The first is that our doctors get higher pay in every category of medical care. And that includes the general practitioner. So if we compare our cardiologists to cardiologists in Europe and Canada, our heart docs get more, a substantial premium. But the same is true of neurologists, surgeons, and every other category of medical specialization, even family docs earning more on average than $200,000 a year, which is enough to put them at the edge of the top 1% of wage earners in the country, at the very edge of that. So Scrooge McDoc jumping into a pool full of gold, according to this guy. Now, the other reason that our physicians earn so much is that roughly 2/3 are specialists. Now, this is where I unequivocally agree. We're backwards. The rest of the world, 2/3 of the docs are generalists. And the generalists are allowed to practice at the top of their license without medical legal liability that we have here. Here, it's backwards. The specialists who are more expensive, who do more procedures, and who are truly a cartel in terms of influence for CMS and the reimbursement that we get. There's much more influence pushing Medicare to reimburse procedures like hips and knees and injections and operations than it is to incentivize having a discussion about end-of-life wishes or promoting primary care and prevention, et cetera. So this is very true, but the thing is, part of it is in this country that we have a legal structure that says, oh, if the PCP doesn't refer to a specialist, he can get sued or she can get sued because it's a standard of care that a specialist sees pretty much everybody. That's horseshit. That's not what happens in other countries. At Turntable Health, we tried to do everything we could within a primary care, well-trained primary care team practicing at the top of their license, and we managed to pull that off. In the rest of the world, they do it too, with better outcomes. What is that saying about our specialist emphasis here? So I agree with him on this. Now, if you go through this, he says there's little evidence of systematically better outcomes in the United States, and the increased use of specialists does not appear to be driven by medical necessity. That's clear. What it is supply drives demand. You have a ton of specialists, and this has been looked at. We talked about it with Robbie Pearl here. You have a ton of cardiologists in a community, more caths get done, cardiac caths get done, than if there are fewer cardiologists in the community. Supply induces demand. And nobody's trying to be nefarious, they just, when you're a hammer, everything's a nail. And you end up doing these procedures on someone who has reflux disease. So, and I'm not picking on cardiologists, and it's anything, right? If Botox is incentivized, people will do Botox. So in recent years, the number of medical residents has become so restricted that even the AMA is pushing to have the number of slots increased. The major obstacle is funding. It costs a teaching hospital, and this is getting to your point, Tom, roughly $150,000 a year for a residency slot.
Yeah.
I don't know where that's coming from because they paid me $33,000 a year as a resident.
Well, they're saying it costs $150,000 to the hospital to teach you because you're dumb and you provide no value.
Yeah, except for the free labor, staffing the ERs and covering the nights, and seeing tons and tons and tons of patients and doing codes that the attending then bills for. So that's what I don't understand. Now, again, we could look at the academic, get an academic CEO on here and say why that is, but it seems pretty expensive. But let's say it's true. Medicare, $150,000 a residency, and most of this money comes from Medicare, and a lesser amount comes from Medicaid and other government sources. Again, if you think government doesn't have a role in healthcare, they're already 50% of the healthcare economy. So you're delusional. You have to figure out how to either fix what government's doing in healthcare or entirely get them out, which is very hard to do. So the number of slots supported by Medicare has been frozen for 2 decades after Congress lowered it in '97 at the request of the AMA and others doctors organizations. Too many residency slots. So according to the AMA, furthermore, Medicare exerts little control over the fields of specialization in which residency slots it supports. So it can't really say cover a bunch of primary care slots. It just says here's a bunch of slots. And it turns out that the hospitals choose the slots, and they're more likely to train someone in cardiology or neurology than a family practitioner because they generate more revenue for the hospital. So policymakers have a number of tools. So this is the problem, all right? Now policymakers have a number of tools to introduce more competition, weaken the doctor's cartel, and get their pay more in line with counterparts elsewhere. First of all, I don't think that's the issue. Again, like I said, Doctors' pay is minimal relative to the total spend, and there are reasons. For example, when we'll talk about student loans, the general ratio of gross domestic product to physician salaries, which we're less out of line than with other countries. We're still out of line, but less out of line relative to how rich the U.S. is. Hold on here. So Medicare could also limit the slots for specialization and instead insist that more of its funding go to trained family practitioners. That I agree with 100%. More family docs, less specialists. And this is no slight on specialists. It means if you really want to limit slot specialists, you can limit them really tight and actually get more primary care docs and pay them well. Or pay them less, a little bit less, but give them a lifestyle, which means they see fewer patients, have better outcomes, have a team to support them, and are paid on real outcomes instead of fee for service, which is the other thing this guy avoids in this article entirely. The poison of fee for service is where supply induces demand. If you have a bunch of doctors, the only way they get paid is by doing things to people instead of for people. That's the fundamental problem here, guys, not doctors' salaries. It's the fee-for-service reimbursement system that we have in this country, and it is obviously inducing the wrong kind of economic behavior. If this guy's an economist, that's what he ought to be focusing on, not on physician salaries per se. Physician salaries are a symptom of a wider issue, if that's even a problem. So they could also fund more residency slots in general. So that's another thing they could do. So a second route would be to end the requirement that foreign doctors complete a U.S. residency program in order to practice medicine in the U.S. This means setting up an arrangement where qualified docs could be licensed to practice in the U.S. So this, to me, makes me nervous, Tom, because you really have to know how are these docs trained in these environments. Mm-hmm. Because are you going to take someone from a foreign country, you don't know how they're trained, and then let them practice here without knowing what the residency requirements are? You'd have to spend a lot of time and money actually researching and going there and seeing that these residencies are valid. So it's a regulatory struggle, it seems to me. And can you imagine you let in a ton of docs without having to do that second residency? You're going to get a huge influx of immigrants, which is going to piss Trump off, of course. But it's more importantly, it's going to piss off doctors who are going to feel then the downward pressure on their salaries, because these docs are going to be willing to work for less as a new immigrant in the country.
A lot less.
A lot less.
Yeah.
And that's going to push downward pressure. Now, if you're an economist, that's fantastic, right? If you care about certain degree of quality and the regulatory fact that we do have pretty rigid standards in the U.S., then that's a problem. So the other thing they say is you could change the rules not only about who can practice, but what doctors can do. So there are many procedures that are performed by docs that can be performed by nurse practitioners and other lower paid health professionals. For example, many states allow nurse practitioners to prescribe medicine without the supervision of a doctor, and there is no evidence that this has resulted in worse outcomes for patients. Now, I reviewed the link that he said there is no evidence that this shows worse outcomes, and that link was pretty vague. So the study was not a great study. So sure, study it, see if it's true, look at other countries where they do that. If it's not true, and I'll tell you anecdotally, the concerns of many people, especially ER physicians who work with nurse practitioners in the emergency department, is that yes, there are many things that nurse practitioners are absolutely perfect at, and they should be able to practice at the top of their game at those things. But when it gets complicated, and sometimes it's hard to know, when you don't know what you don't know, that can get very tricky. And we've talked about this in other shows. So allowing unsupervised practice is still a very gray area, right? And a lot of doctors will push back very hard on that because they feel it's an erosion of actually the practice of medicine. So this is a thing where you just got to study it really well and see what actually is the answer. Here's the thing, and that's a hard study to do. So one more approach tested in Missouri, Kansas, and Arkansas. Doctors who haven't completed a U.S. residency can come and work under the supervision of another doc. So that's almost like a super nurse practitioner, right? Somebody who's gone through medical school, which, again, we've talked about this. Medical school, okay, I'm going to just be very clear for a second, especially for my colleagues in my MD and DO colleagues who feel like I don't say this loud enough. I'm going to say it loud enough right now because I believe this. Unless you've gone through medical school and residency, you have no effing clue how much work we put into our educations as doctors. Now, you can say we don't know what nurse practitioners do and PAs do, and that's kind of true, but I will tell you we put a lot more hours work training as a medical doctor, which means that's why we ought to be practicing at the top of our licenses, doing the shit that only doctors can do, right? And the stuff that other people can do safely, and we show that it's true, let them do it. But if doctors, listen, there's stuff that only doctors can do, and there's a reason for that. There's a reason that we get compensated the way we do. We bust our damn asses and learn a shit ton, and we take care of people really, really well. And we sacrifice a lot to do that. And that's true across healthcare, but medical doctors do it to a degree that I will argue, having gone through it, is pretty freaking insane, all right? So my peeps, my tribe, we sacrificed a lot. And so when an asshole like this writes an article like this that says, let's just cut doctors' pay, I want to punch him in the face because he doesn't understand that, first of all, it's a drop in the bucket. Second of all, you haven't fixed fee-for-service. Third of all, you haven't fixed malpractice, because we're forced to practice stupid, litigious avoiding care because we're afraid we're going to get sued. We have too many specialists, not enough primary care docs, and loans. Medical education is fucking expensive. It's not true in other countries. A lot of times it's free or subsidized by the government. We don't have that here. You come out on average with $200,000 of debt. Come on. That's debilitating. It forces you then to specialize, to do procedures, to try to generate revenue. And that is not a fair comparison to other countries. So this guy is a great, in my final stamp, he's an asshole.
Plus, it's economic suicide to do that, to put yourself so far in debt so young. Even if you have a high salary, you've put yourself into a massive hole that you have to dig yourself out of. You're not going to have the benefit of compound interest to the extent that you may have if you had just taken a different job earlier on in your career. Most people start earning money at 22, real money. And doctors don't start earning real money until they're 30. So there's an 8-year gap there that makes a ton of difference.
What you just said is something that many people don't understand, which is this idea of opportunity cost.
Right.
The idea that all that time you were shitting around in medical school getting debt. Other people were doing stuff that was generating revenue, saving for their Roth IRAs, doing X, Y, and Z. They're going to come out so ahead of you, even if they just work a trade that, which, by the way, with
even if you make $60K a year, you can come out way ahead of most doctors.
Way ahead.
Yeah.
You two assholes are so far ahead of me at your age in your 20s than I was when I was a doctor.
Well, plus there's the pressure to live like a doctor,
Right.
and like
delayed gratification.
Yeah, not have your wife work or not, support your family if you're the breadwinner and drive a BMW and look like the guy or the girl who's, killing the game, but like really the economics don't add up for any of that.
They don't add up at all. And in the end, we get paid for all the hours and time and loans and everything we make. We get paid what, like a metallurgist, more or less. So what someone in a skilled trade would get.
If you add up all Kevin MD had an article that said if you add up all the hours that doctors work, they get paid like somebody in the skilled trades, right? They're just working way more hours, because you're working like 24 hours at a time. So.
Yeah. Well, and here's the thing. So the end of this article, and we'll wrap it up, if we want to stop paying a $100 billion premium for healthcare that doesn't make us healthier, we're going to need to overcome those political barriers to the doctors' cartel. Getting U.S. healthcare costs down is a Herculean task. Getting doctors' pay in line is a big part of the solution. Are you high? A big part of the solution? Can you do math? It's time we broke up the doctor cartel. The fact that most people like their doctors will make the effort harder. Most of us like our letter carriers too, but that doesn't mean they should make $250,000 a year. Okay, just parse that for a second, Tom.
By the way, who the hell has a letter carrier? What even is that?
Yeah.
Is that a postman?
B,
I don't know
he
my
compared
postman.
us to mailmen, which no offense to mail carriers. They don't go through 8 years of school, sacrifice their nights and their children, to fucking click boxes on Epic and put your hand in somebody's chest cavity and massage a beating heart. They don't do that shit, so of course they don't make $250,000. Should we pay teachers $150,000 a year? Probably, because they are actually affecting people's lives and hold them to very high standards, right? This is all true. Is life fair? No. Can we make it more fair by fixing the big shit and not trying to demoralize our healthcare team more? Through this kind of thing? Yes. Should we have more residency slots? Yes. Should we have less specialists? Yes. Are doctors overpaid? No. But we can make them more correctly paid by changing all those things, and doctors will still make a great living, will have better support, and have outcomes that matter for the whole country. What do you think, Tom Heineberg? Any comments, anything you want to read?
I think it's time to wrap it up.
Hell
also,
yeah.
people that say that teachers should make $150K a year, Yeah, minus $25,000 because they don't work 2 months out of the year. So let's bump that down to 125 people. You know what I'm saying?
That's right. Suck it, teachers. You suck. Lazy.
And we're out, people. We're out. Buy some Bitcoin, doctors. You'll be rich one day. Probably not.
Scrooge McDoc. Life is like a hurricane
Here in Docburg, razors, lace cars, Medicare. It's a Doc blur.
Might do a cabbage
Ba-da-ba.
or rewrite cabbage.
Ba-da-ba.
Hotmail. Ooh. We're out.
Cut.
Go, 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 go. That's the birthday. That's the birthday.
Yo, Z-Pack! This episode is made possible by the generous sponsorship of Athena Health. Athena Health partners with hospital and ambulatory clients to drive results. They offer network-enabled medical record, revenue cycle management, patient engagement, care coordination, and population health services to build Health 3.0. Yo, get back to the work you love doing. Athena Health. Free up.